If you like, you may applaud. It's of course a very specific format here, but I do hope that you really concentrated on the content. And what I learned actually today is even that the practice, real life experience seems to be even more convincible and more fantastic than what we see and what we saw in the studies. And also in the studies it was already very, very impressive. I do have the possibility to get your questions either by just going to the microphone, and I will also check whether we have any other questions from the audience. Otherwise, the iMessages I have here, so everything is virtual nowadays. And I hope I can open this question. There was a first one saying, should coexisting type 2 inflammatory conditions be taken into consideration when managing a patient with chronic rhinosinusitis with nasal polyps? Yes, of course. Most of that comorbidity will be comorbid asthma in our patients, and you saw it here also in the range of half of the patients, up to 70% of the patients have some form of comorbid asthma. If there is a severe asthma with nasal polyps, in our tradition mostly the pulmonologist takes over to treat this severe asthma. If it is not severe, that is on us. Of course, the patient has already medication for the treatment of asthma prior to any interference here with dupilumab. But of course, once the dupilumab is actually given, of course you can feel sometimes, and this is some unofficial statement, that some of the patients get a bit lazy taking their other medications, and that could also include, of course, the asthma medication. Officially, we always encourage patients to take their medication further, also topical steroids for the nasal polyps. But of course, we understand also our patients in that sense that they really are tired of doing that for many years, and if they don't feel it's necessary anymore, they might be a little bit floppy with that. Now let's see whether I have any other questions. But please ask your questions live. Aside from eosinophils, what biomarkers of chronic rhinosinusitis will likely correlate with biologic efficacy? Unfortunately, not even the eosinophils really correlate in that sense that there is a strong correlation between the relief from symptoms and the number of eosinophils and how they go down. Of course, what you see here is that any type 2 cytokine would go down with the treatment, and with that, at the same time, the symptoms go down. But it's not like you could say that a specific biomarker is really giving you all the answers. You still need to talk to your patient, and you still need to look into the nose. But of course, there is a correlation, but it's not a patient individual association with the reduction in biomarkers and the symptoms, and of course the CT scan and the nasal polyp score, and the need for corticosteroids, for example, oral corticosteroids or further surgery. This said, I just wanted to remark that in these trials there was also a clear reduction of the need of oral steroids, episodes of oral steroids, and also for surgeries. Surgery numbers are small over this 1 year of the trial. And again, here we will collect much more data in the future with registries such as the one presented, looking into the consequences in further surgeries, in terms of further surgeries and oral glucocorticosteroids. We had, by the way, who is interested, 314 viewers on the internet, so we are actually about 400 patients here, 400 visitors here, and audience. What potential differences are there between real-world dupilumab data and phase 3 data? Absolutely. Why is that different? Well, one of the things is always how to find the right patient. You will have a lot of patients trying to come. I had patients already saying, oh, I've heard of something new, can I have this? But it's really, and you see that very nicely documented, very important to select the patients adequately. So what we say is the patient has to suffer from nasal polyps by both sides. That's clear. An antrocoronal polyp doesn't count, not an indication. Other forms of diseases are not yet an indication, and also chronic rhinosinusitis without nasal polyps is not yet an indication. Maybe it comes because we know that also 50% of CRS without nasal polyps is actually type 2. But of course we can't see it so easily. The eosinophils might not really give us the answer, so that's more delicate, and you will hear from that in the future. What other differences are there? I think when we start with really the severe patients, polyp score of 4 or more, you can use the 5, but in my option, in my vision, if there's a polyp score of 4 and they are really symptomatic and have a decrease in quality of life, then they qualify also. It should be uncontrolled by topical glucocorticosteroids. That's very clear. Nobody would like to also pay from the payer's perspective for a biologic to spare topical steroids. That's, I think, obvious. And they should also be uncontrolled by either form of surgery. It doesn't need to be new surgery, it can be years back, or oral steroid courses. And we know very well that oral steroids, they have a peak effect maybe after 2-3 weeks, and then this fades again away quite fast. So these criteria have been built in to at least, not treat everybody with nasal polyps with a biologic for obvious reasons. Otherwise, what we do in practice is the first thing we want to know, of course, this is type 2. And we published an algorithm on that very clearly, just looking at asthma comorbidity. If you have chronic rhinosinusitis in any form of asthma comorbidity, not just eosinophilic asthma only, you have a 95% chance that you have type 2 nasal polyps. That's high enough. If you have no asthma comorbidity, but your eosinophils are above 300, you have another 95% chance of a type 2 immune reaction also in your polyp. And the combination of the two is even 98% sure that this is type 2. I think this should help us to get a sort of easy thing, not measuring hundreds of mediators, which is difficulty in a routine lab, but if you just have asthma comorbidity eosinophils as a marker, then you know this is type 2. Is there anything that would give you further idea on what biologic would help most likely? Well, if I see the real life data here for dupilumab, the responder rate was very high in real life, and that is very interesting. So I think choosing the right patients, as I just said, should help you to get similar success rates. And that would be, of course, fantastic. There are always patients where that doesn't work, but few, and there are always patients who have a contraindication, who don't feel well, who are not, following the rules to actually really get this medication regularly, for example, non-adherence and so on. But the majority of patients will actually follow that. Does it mean that there is no surgery anymore necessary in the future? That is the next question, especially surgeons coming here would like to hear about surgery. I always turn it around and say, well, isn't that fantastic that we can make our surgery now really lasting a long time? And the approach to that might be in a patient who had surgery 5 years ago, to start with a biologic now, before you talk about surgery again, but you can say that there are some patients where the resolution will not be complete, and there might be surgery in a different form necessary. And then you do treat with a biologic for 6 months, maybe for 12 months, if you see there's a response, but it takes somewhat longer. If it's fast as this case here, then you don't even need 6 months. You just know that after 4 weeks already that no surgery is necessary anymore. But in some patients that will take some time. And then you could, under the protection with a biologic, and for that reason we are just writing a paper where we had several patients operated with the biologic, you can perfectly do a surgery which is then of course smaller than originally planned, maybe 6 months before, in these patients if necessary, and that would complete your reduction to polyp score 0, so to speak, and would maintain a perfect condition for the patient in the future. So you can do surgery under the biologic, which actually heals perfectly, because what does disturb healing, as we heard in my first presentation, is type 2 immune response. No epithelial integrity, a lot of mucosal glands, a lot of weak tight junctions. Healing under a biologic is just incredibly fast, and I have not seen in any cases we did surgery in any problems with that. So I think that's the best way. If you decide on a long-term perspective, do the biologic, see whether you need a surgery at that time point, and you will have, of course, a reduction of those patients where you still do surgery. Might be depending on the biologic also, and dupilumab, the data you have just seen, and then you continue. The question I always get is, can we stop at one time point? And that's a question that we can, at the moment, rather answer with no. Because once you stop, even if it's after 1 year, you will have a slow recurrence. Can be 2, 3, 4 months that it takes to really make a difference for the patient again. But there obviously is a memory in this nasal epithelium that will make these polyps grow again. So in other words, the alternative to that stop might, of course, be playing a little bit with the dosing intervals, with the dosage, but that is very speculative at the moment. Nobody can give you rules. That's why we do these registries, to see how in the future we best handle also the balance between costs and profit. And it might be clear for us nowadays already that treating a full-blown disease is a different thing from maintaining a disease-free status. And you can play with the dosages. But that is something we all together best in a registry figure out in the next years and months, hopefully already. Exactly, so I was talking about the combination of surgery and biologics. Is there any marker that predicts that a certain biologic will work rather than another one? You saw mepolizumab. It seems that those patients with less than 150 eosinophils per cubic millimeter is actually, per microliter, sorry, is not yet secure in a way. We wouldn't say, well, that's not an indication, but of course we feel that to have a better start with that treatment, we rather go to those with a more eosinophils above 150. 150 should be easily reached. The average of the patients we saw here was 240, 250. The other thing is the limitation for IgE. So if you do omalizumab treatment for these nasal polyps, the company tells you the IgE should at least be 75 and should be not higher than 1,500. And that has to do specifically with the combination of the IgE value and the weight of the patient to calculate the doses. So the dosage might be extremely high if you have a IgE of 5,000 and a 120 kilo person. You might get a little bit of trouble to put that together for that patient. And of course, you could easily go to alternatives. I would like to hear from you when you hear these results. Is that a threat for you because you think about your surgery you like to do? Or is it a clear benefit? Do you understand it as a benefit or a threat? So let's say, raise your hands if it is a benefit. Okay, if you raise your hands now if you think it's a threat. Okay. No threat. Oh, half a threat. Okay, half a threat, but more benefits. And I think, again, that one is something that will come into our clinical practice with more and more experience in how to handle these patients. There's another question?
Prof, can I ask a question?
Yeah.
To your left.
Okay.
Hi. So about dupilumab, after 24 weeks, how do you decide what frequency to treat your patient? Is it monthly, or do you carry on with fortnightly?
Yeah. According to the trial and according to the indication, it is just, continuing with the same scheme. There is no such variation of the dosing and intervals foreseen at the moment. I think that is something that will come and only come in those patients where really there's no polyp load anymore, polyps disappeared. I think that is something that will come from practice rather than from the indication. The indication is very clear at the moment, but again, we learn. We are in a phase of learning at the moment. I think we will learn fast, and each of us will make experiences and his own experiences. So I think it is something that will be discussed in future meetings more than today. What we have today is the first results, but you also saw the results from Amsterdam, where just 12 weeks treatment. So again, there we need more really experience. By the way, who of you is already treating with biologics? 1, 2, 3, not so many. 4, 5. Okay. Good. So there needs to be work on that also. Yeah, please, another question.
Good morning. My name is Anatoli Pataridou. I am an ENT. I work in a private hospital in Athens for 26 years now. And really, congratulations to all the panelists. And I really feel very enthusiastic about all those new weapons. But I want to, it's not really a question, it's mainly a comment. I feel during all those years that many times surgeons, we feel very keen on operate, but we don't focus to the post-op follow-up. So I believe that we lose what we call individualized the treatment to any patient. From my experience as a surgeon, I believe that this is a main parameter, and we have to focus on this intensive follow-up post-op, because every patient is a different type of patient, and we have to learn from our cases, because it's not only the papers, it's not only books. We know that during our experience, if we have this intensive follow-up, and if we love our job, and if we hear to any patient, we find during the day and every day so many little things that are crucial and change the whole thing. So it's a great deal to have a weapon like that, but the indications for weapons like that, for new operations, for new equipments, it's not the only topic. The main thing for me after so many years is to palpate our patient with our hands, with our ears, with our nose, and to realize the lifestyle of every patient. For me, it's very important. I learn so many things from my patients, even from the pillow that they use, even from their diet. And I believe that when we discuss about allergy, about non-polyps, polyp situations, and about some multifactorial, let's say, disease like that, it's very important to realize that we have to learn from every patient. Usually we don't put a lot on that scenario. I don't know, I really want to hear your opinion.
Okay. I have a lot of questions here coming in. Of course, they are slowly coming in. I do absolutely agree. A nasal polyp patient for me is always a long-term patient. We see them regularly back in the first 3 months after surgery, for example, also in the biologic treatment, every 3 months for the first year, then every half year, and at least once a year, even after the 5th year. We did once a study where we looked at a group of patients over 12 years, and the total percentage of recurrence over these 12 years after surgery, for example, was 78%, but half of them just need 2 years, the other half needs 4 years, 5 years to come back. So you actually keep observing them, and you should absolutely keep treating them depending on what they have for their asthma and for the nasal polyps. There's always a sort of a local treatment with topical steroids, and we do a lot of rinses with steroids also in these patients. Absolutely necessary. Thank you for the question. There is more questions here, and I will try to see whether I can answer more. Is there an impact of multiple previous surgeries versus only one on the response to biologics? We saw that this was not the case here with dupilumab in this study. Is biopsy important to indicate the biologic? No, but of course, if you have former material that someone got from a surgery 5 years ago, please look at it. If they find eosinophils there, the new polyps will also have eosinophils, very clear. Do you have any experience in Church-Strauss syndrome? Yes, there are studies on similar syndromes, but not into a great deal. These are very seldom patients, and I have personally not seen any Church-Strauss. But however, you always have to remember, sometimes we see these patients and don't know yet that they have the full syndrome. Aside from eosinophils, which other biomarkers will correlate with biological efficacy, all these biomarkers go down, but none of them is predicting the response here. So what you will see, whether you look at ECP, for example, is a cationic protein that will go down with the ears, of course, but you will also have chemokines for eosinophils that go down with the IL-4 treatment. But again, it does not correlate 100% for the individual patient. It does not correlate with the markers and the symptoms. So look at the symptoms, look into the nose is my strict advice. Can biologic therapy affect patient outcomes when coupled with sinus surgery? As I said, I think you can combine that if necessary, but give the biologic a chance first and see what is necessary. I think here is the message. Should coexisting type 2 inflammatory conditions be taken into consideration? Yes, of course. Again, asthma is the first thing. We do that with our pulmonologists together. If there is other disease, eosinophilic esophagitis, we didn't see a lot of patients yet in our patient group, but if that is seen, again, yes, and you should consider it together with the person who treats the patient for that disease. I think it is extremely interesting then to have a very clear cooperation and discussion with each other. Now see that there's that was it more or less. You have another question here, please.
Yes, I'm Roy Landsberg from Israel, and I'm a great fan of the new biologic treatment, and I'm a great fan of surgery. And I see it as a benefit, not as a threat. And when I see a patient that is bad patient after surgery, I'm very happy to offer him this treatment instead of another surgery. However, when he comes for me at the first time and I see polyps and I don't know this particular patient, how will he react to surgery, I will still offer him surgery because many patients, I cannot tell exactly the percentage, will benefit from surgery even without, I know it's something not everybody will accept, even without any local steroid treatment, okay? There is a significant number of patients that if you do the complete surgery will be very good, will feel great for years. Okay, maybe not for many years, but for years. Now, I see it as an advantage when you compare it to every 2 weeks an injection. And what do you think about that?
The difficulty here is certainly to predict that patient.
Yes.
If you have a patient who really doesn't need anything anymore for the next 10 years, perfect. But how do you know that at the very beginning? I think that's extremely difficult. What we regularly do, of course, is put them on topical steroids and they stay on steroids. We consider, even when we do surgery, we have different rules. In our country, and I think in whole of Europe, when you talk about surgery, you have to mention the risks and complications. That's clear. We are all used to that. All surgeons are used to that, and you have to put that in a relationship to the benefits of the surgery. But we also are obliged to talk about alternatives. You cannot say, I'm the surgeon, I do now surgery in you, and there is nothing else. And if you talk about alternatives in the future, biologics will play a role. It's very clear that so before you even talk about, or before you even get the patient into surgery, you will have to mention as an alternative.
Absolutely right. Now, many patients, when I give them this alternative, that one alternative is an optional few years of feeling great, and the alternative of biologic, they say, I want that silence first for several years to try it.
Yeah. The point here is you're absolutely right. It is the right of the patient to decide. You cannot not face or force a patient into one or other treatment.
Absolutely.
They have to decide. That means they have to be clearly counseled. They have to know what are the advantages and disadvantages of whatever treatment. That is extremely important. My question to the surgeons at that moment would always be, what kind of surgery are you actually talking about? And in the surgical world, I think I can say that in the last 2 minutes without half an hour further discussion, it is not really decided. We do have different approaches with surgery. Some are more careful. They open the sinuses, they take the polyps away, but they would not treat it because in the sinuses. Are you actually skilled to do that, to the opening of the frontal and the skull base and the lamina orbitalis? Are you daring that? Do you have the time for that? I see a lot of colleagues that have a sort of operation time of 30 minutes per patient. You cannot do that if you are not extremely trained to do that kind of surgery in that time. So there's a lot of factors. And I think the ENT community would be very good advice to really discuss what kind of surgery you would do in a full-blown type 2 uncontrolled severe chronic rhinosinusitis, and how is that different from a non-type 2 CRS without
Mm-hmm.
And I think that is a little bit the task. It's a challenge for the surgeons now to figure that really out, and then people can say, well, I can do that surgery, I have to send the patient to a hospital to do that surgery, or in the discussion with the patient, clearly we decide for a biologic, and that's where we start with the surgery in the pocket if still there. I think that's how I would say.
Thank you.
There's another question?
Prof, thank you all for your wonderful talks. Just a quick question. I'm from the UK. These drugs obviously have a huge health economic cost and an indefinite length of cost, which is unsustainable in some health economies. I just wondered, I mean, obviously with time, if more people prescribe it, the price point will come down, but at present, it's an unsustainable cost. The other thing I would just like to say is as you alluded to, you are emphasizing a paradigm shift. I'm a rhinologist, I enjoy operating, and I think most honest rhinologists will see this both as a benefit to their patients, but also as a threat. It's both. I think we need to look out for the benefits, but in the data that Claire showed, she was suggesting most of our patients who come to us in tertiary centres come to us having already had a couple of surgeries. So certainly the data that she showed suggested a significant benefit of dupilumab, but not of mepolizumab. So are you currently advocating one over the other?
Well, the first thing I would say, I'm in the perfect position of working as a professor at a hospital. Nobody ever approached me saying, oh, you are spending too much money. That's perfect. So in my view, there is the patient and there is the payer. But I'm not linked to the payer, I'm linked to the patient. For me, the patient is the center. That's how I always would see it. And I would also defend that against the payer because, well, I'm not making the prices. There is a discussion between them. So I don't want to mix it. For me, I really concentrate on the patient. Of course, when the costs come down with, competitors, we have 3-4 biologics. I mean, prices might move. Maybe, it depends a little bit more how effective these biologics, prices might move from different biologics more than from others, and things like that. This is a system, and that is what we do in every move. This is, decision based on what you get for your money, and that is a continuous thing. I certainly would say we can count on that this will be reduced at the moment. As soon as we can do it in more patients, we will do it in more patients. I know that in Germany there's more than 4,500 patients already on the drug. If it is, difficult for the payer, at a certain time point, they come back to us. They did that for immunotherapy. But immunotherapy still lives and still is paid. But again, what is very important for you to be on the safe side is, here are the indications. I have ticked, yes, this patient had systemic steroids before, or surgery. This patient has severe disease. This patient is likely type 2, has asthma comorbidity, yes or no. So you have, I think, to document yourself as much as possible what drives you into that decision. And if there's any problem in responding to the authorities, otherwise, just send me an email.
And what about the difference between the two?
Oh, you know, at the moment, what we see is differences. Are these differences real? Of course, the patients in the different studies were not done in the same population. It's not the same population at least. What we really normally need to say there's a difference is a comparison, head-to-head comparison of two drugs. And that will happen. I know that this will happen. At the moment, what you can say, again, it's not a simple answer. What is available? In some countries, I hear omalizumab is available, but dupilumab not. In the other countries, it is mepo, and so on. What is available? What is the balance in your idea between the benefit, because the benefit is not the same for all of them, and the price? So this is where you are. And what I always advise you, if you were the patient, what would you think is the best for you? And with that, I'm happy to close here. Thank you so much for the questions. We had a, I think, very lively discussion also. We live from discussions, and we hope to see you again and have a lot more nice experiences at this congress, either virtually or in person. Happy to talk to you if you meet me later, always. Thank you so much.
See you, right? See you. It's good seeing you. See you. Yeah.